following episode is brought to you by the American Urological Association.
Good afternoon. My name is Raman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this being one of the episodes that focuses on a chapter from our core curriculum. Specifically, we're going to be speaking about kidney cancer and the role of radiation therapy in the management of this disease. It's my pleasure to host Dr. Dan Shapiro, who is really a superstar in the realm of urologic oncology. He is an assistant professor of urologic oncology at the University of Wisconsin, where he did his residency, and after which he attended the MD Anderson Cancer Center and did an oncology fellowship before returning back to Wisconsin. His clinical practice focuses on kidney cancer, as does his research interests. And he has been kind enough to give us a little bit of time this afternoon. Dan, delighted to have you, and thanks so much for joining.
Yeah, no, thanks a lot for having me. I'm really excited to be here.
I almost committed blasphemy right off the start by attributing you to Memorial Sloan Kettering instead of MD Anderson. I'm sure I would have gotten some emails from your mentors down at Anderson reminding me exactly where the fellowship occurred. But
yeah, I can hear Brian Chapin in my head.
Right. So Dan, the concept of radiation therapy, I mean, I feel like for urologists and urologic surgeons, we obviously have long embraced the concept of surgical management for kidney cancer. Obviously, as time has gone on, we've become more accustomed with minimally invasive approaches for kidney cancer. We've embraced partial versus radical nephrectomy. And the concept of active surveillance has also sort of permeated more into practice. But I would still tell you, and I'd like to get your thoughts, I feel like the concept of radiation therapy is one that is still something that many people are not wholly familiar with, nor comfortable with. And I think it was our hope and goal to do this podcast to better educate people as to how this other modality can kind of fit into the entire algorithm of kidney cancer. Am I sort of contextualizing that maybe the right way?
Yeah, I think you're exactly right. I think, full disclosure right off the bat is obviously I'm a surgeon first off. And so I'm going to try and have the least amount of bias in terms of our discussion right now. But yeah, I think you're absolutely right. I think, primarily we think about kidney cancer, at least early stage kidney cancer, as being a primarily surgical disease. And then we've expanded over the years with ablation therapy, and we do a lot of ablation here at UW. And then also, the field in general has been expanding in terms of active surveillance. And now we're starting to see more and more literature on using radiation in RCC. And I think this is kind of against the previous notion that RCC is a radio-resistant disease. And a lot of that perspective came from a lot of older studies. Initially, radiation was tested in cell lines in vitro, and some of those cell lines that it was tested in, for example, we use in the lab, the ACHN cell line, that cell line was derived from a malignant pleural effusion in a 22-year-old. So that's a pretty rare type of RCC presentation. So you kind of have to put that in context and understand, how was radiation initially being tested to determine if it was resistant? And then also a lot of the older studies were using less powerful and not our modern type of SBRT regimens. So I think that notion is starting to be dispelled, and radiation is becoming more frequently used. It's just, we still have to narrow down how it's being used and what is the ideal patient to select radiation for. And that's really, I think, the crux of what we're discussing today.
I think that's a great way to contextualize it. And that was really eye-opening for me when you talked about sort of what we base a lot of our initial presumptions on. And it may be on sort of somewhat flawed data, not necessarily the data we get from it, but the flawed premise of looking at a cell line, which probably doesn't reflect the majority of kidney cancer that we see in the population, either from the fact that it's metastatic or from the fact that it's originating from a 22-year-old, which demographically is almost 4 decades younger than the average kidney cancer patient. So I thought as we were going through this, and it would be most helpful for our listeners to sort of think about and have you talk to us a little bit about radiation therapy, but maybe let's focus on several different disease states. I think obviously we think about diseases localized, advanced, and metastatic, and that's kind of how we think about it. And I think that's probably a good way for people to understand the role of radiation. So maybe start off and just talk to us a little bit about radiation use just for primary kidney tumors, maybe a little bit on whom those persons may be, and then we can even talk about some of the side effects, toxicity, efficacy, so on and so forth.
Yeah, I think, using radiation therapy for primary RCC, I think is one of the more difficult pills for us to swallow as surgeons, that we have surgery and ablation therapy, which have been more commonly used, and then also active surveillance for smaller renal masses. But I think credit to the radiation oncology field, there have been some pretty well done studies looking at radiation for primary RCC. Now, I kind of wanted to highlight a couple of those studies. I think one study came out this year was the Fast Track 2 trial. And so that was a multi-institutional phase 2 trial, and that was just published this year in Lancet Oncology. And I think it helps to look at that trial because it kind of contextualizes what types of patients they're identifying to be treated with radiation therapy. And so their inclusion criteria in that trial was the patients had to be non-metastatic, and importantly, all of the patients were biopsy-confirmed RCC. I think anytime we're evaluating the use of radiation therapy in primary RCC, we need patients to be biopsy-confirmed because that can really bias the outcomes in terms of whether or not the tumor progresses or the patient develops metastatic disease. So in that trial, nicely, that all of them were biopsy-confirmed. And then the patient had to be deemed medically inoperable or the patient declined surgery. Now, that gets a little hazy because I think, people can argue what patients are medically inoperable. And obviously, if a patient declines surgery, that's different. But there can be a little bit of bias associated with that. And then they also included tumors that were less than 10 centimeters. So, and then that trial, they kind of standardized how the radiation was delivered. So if you look at a lot of the retrospective series before that, there's lots of heterogeneity in how the radiation is delivered. But in this trial, they gave just, a standard regimen to all the patients, which, reduces some of the confounding there. And so then in terms of how they identified local control, they looked at local control based on the investigator's assessment. And then they use the RECIST criteria. And so if you're not familiar with the RECIST criteria, if a tumor grows less than 20%, then it's considered to be controlled. So that's kind of an interesting point that brings up one of the issues surrounding radiation therapy in primary RCC is how do we define that the tumor has been ideally controlled or destroyed? So one of the issues with radiation therapy is after the radiation is delivered, the tumors often still enhance. And then even by their own criteria, the tumor may slowly grow over time as long as it doesn't meet that RECIST threshold. So there's a little bit of ambiguity there. And obviously, that's just how radiation is. We have to kind of accept that as, that's kind of the endpoint that we're dealing with right now until something better is developed. But I think, this trial showed that their local control rate at 12 months was 100% based on that criteria. So the tumors obviously weren't growing much in that 12 months. Mm-hmm. Now, again, you could argue those tumors were relatively small. The median tumor size that they accrued was 4.6 centimeters. So we don't expect those tumors to grow relatively quickly. And, the median follow-up for this was 43 months, so not a huge follow-up. So I think, they showed that the local control rate was effective, but we don't have a long follow-up, and we don't expect these tumors to grow particularly fast. But they did demonstrate, the local control rate was really high, and then the metastatic free rate at 12 months was 97%. So I think in general, in these patients who were medically inoperable, quote unquote, the local control rate was high and not many of them metastasized. So I think it demonstrates that radiation was safe and feasible, and at least with this kind of shorter term follow-up, there was a reasonable control rate. So I think that kind of puts in context the types of patients we're talking about when we're selecting patients for radiation therapy.
Talk a little bit to us, just maybe in your own practice, as we just sort of look at localized kidney cancer. And you gave us a really nice, and that is probably one of the real sentinel papers published that at least has data. And you highlighted some of the positives and the negatives with regards to data interpretation. Talk a little bit about it, your practice at UW. How does the concept of radiation therapy, how do you juxtapose that with thermal ablation, whether that be cryo, radio frequency ablation, microwave? I know you have a very active ablation program as well. So maybe just give our listeners a little bit of a sense. Localized kidney cancer, 3-4 centimeter mass. How does one pick A versus B? Or is there certain criteria that push your team in any one direction?
Yeah, I think that's a really good question, and I'll try and keep the discussion short because you could go on for hours about how you select these patients. But I think in general, for localized kidney cancer, young patients, otherwise pretty healthy, surgery is going to be your primary treatment. So I'm talking, less than 60 years old, and they're doing well, they're very active, great performance status. Surgery is going to be our primary treatment. As people get older and maybe they're a little bit higher risk in terms of their potential surgical morbidity, and they've got just a smaller renal mass, then ablation starts to come into the picture. And then also, depending on the size of the tumor and, patients who are really old, then active surveillance becomes more relevant. But I think in terms of ablation therapy, those patients ideally are high-risk surgical candidates. Again, that's kind of in the eye of the beholder, but I think we're pretty aggressive surgically. But patients who we feel would be high risk for surgical intervention, but they've got kind of that borderline renal mass, 3-4 centimeters, that maybe isn't necessarily a great surveillance candidate, then we'll talk more about thermal ablation. And, we have a lot of discussion with the patient and figure out, what's important to them. If we're going to go down the ablation road, typically here at UW, we use microwave ablation. We don't really do any RFA anymore. And then cryoablation, we typically limit for either, tumors that are more centrally located where we don't want to get a collecting system injury. And then also in patients who are microwave failures, maybe they progress after microwave ablation, then we'll typically use cryoablation as sort of like a salvage treatment. And then talking about radiation therapy, so right now we don't have any comparative data to look at to say that radiation or thermal ablation are better. I think the radiation oncologists, to their credit, have done a lot of phase 2 trials. However, a lot of those trials are single arm, they're not randomized against any standard therapy. So we can't necessarily say that radiation is better than thermal ablation. And we certainly have more experience with thermal ablation. So we typically lean more on thermal ablation for those quote unquote high-risk surgical candidates. Radiation therapy is really those patients who can't even tolerate a general anesthetic to get through the thermal ablation. So that's pretty rare, but we do see that from time to time. And they've got a tumor that maybe isn't a great surveillance candidate. So we've already seen it progressing. It's getting 4 or 5 centimeters. We're worried about its metastatic potential. Those are patients then we would consider radiation. And we've got great radiation oncologists here who, we've treated some patients with radiation and they've done well in the short-term follow-up that we've had with them. But it's a very nuanced decision, and it's definitely not like a one-size-fits-all. So,
sure. And I think, I think for our listeners, probably one of the most important take-homes that, I would say from what you've discussed thus far is the critical importance whether it's radiation or even thermal ablation of biopsy, so that we actually know what we are treating. And going back to that first point that you made, that many of these may necessarily, even at larger sizes, be slower growing. Some percentage are going to be either indolent kidney cancer histologies or even benign renal masses. That seems like it's a critical element as we look at need for therapy, but then obviously looking at effectiveness of treatment. Is that sort of an accurate statement?
Yeah, absolutely. I 100% agree with what you said. I think we're very biopsy forward here at UW. Before any patient gets an ablation, or now with radiation therapy, we get a biopsy beforehand. And with the ablation patients, some sites will do the ablation in the same setting with the biopsy. So they get the biopsy and then go right to ablation. We make a point of doing our biopsies before they get to the ablation suite, so that we can discuss the pathology with them and potentially avoid an intervention. A lot of times we'll see oncocytomas and things like that you can safely watch, especially in these highly comorbid patients.
So, you've provided us a really nice context when we look at localized kidney cancer and certainly a spectrum of sizes. Let's kind of go to the next, the next sort of level per se, which is these locally advanced kidney tumors, maybe even those with thrombus, whether renal vein or vena cava thrombus. Talk a little bit about where does radiation and how does radiation perhaps fit into these locally advanced renal malignancies?
Yeah, I think this is a particularly very niche area because, first of all, tumor thrombus with RCC, if we're talking about locally advanced with a tumor thrombus, that's already a fairly rare occurrence. We obviously at the academic centers maybe see a little bit more of those, but that's already a rare situation. And then surgery is by far and away going to be the first and foremost method of treating those. Surgical excision is important. However, there are those very rare patients where their disease or their performance status is so advanced, they're just high-risk surgical candidates. What comes to mind often is the level 4s or the Budd-Chiari syndrome, where they've got hepatic outflow obstruction and they've got liver dysfunction. Those patients are just extremely high-risk surgical candidates. And I think most people who do a lot of thrombectomy would agree, the mortality rate just from doing surgery on those patients is quite high. Mm-hmm. So that's kind of an area where we've explored more using either neoadjuvant therapies or combining neoadjuvant with radiation therapy. Sometimes you need just enough tumor shrinkage or tumor necrosis to relieve some of that hepatic outflow obstruction, for example, in the Budd-Chiari patients, that can improve their performance status and their morbidity from surgery, and then you can go and surgically resect them. So I think we use radiation in very unique situations in that setting, but there is some data to show that that's effective. There was a retrospective series that looked at a multi-institution series, but they only, even including multiple institutions, they had 15 patients. This was a paper by Freifeld et al. Out of urologic oncology, and they had 15 patients who had tumor thrombi, and they followed them for 19 months after giving them SABR therapy, and the median overall survival was actually 34 months in these patients who got radiation therapy. So, and some of them, like I said, received radiation for symptom palliation and Budd-Chiari syndrome, and so sometimes radiation can be effective in sort of delaying the disease progression and also just giving you that little bit more to improve their performance status, so then you can go and surgically resect them. So I think by far and away, the main point should be from this is that, surgery is the most important therapy up front, but radiation or even combination systemic therapy with radiation might give you that little bit you need to get them to the operating room.
Yeah, and as you said so well, and you gave the Budd-Chiari example, there are these patients who you really know are not going to do well with surgery. These folks that have hepatic dysfunction, dysfunction in their coagulation cascade, maybe qualitative or quantitative platelet dysfunction, where you say to yourself, if there's anything that can improve their disease before surgery, it may be the difference between them getting through the operation or really having a bad surgical outcome, or a very long convalescence in the hospital.
Yeah. And I think one thing I learned from some of this literature too is, a lot of times the radiation therapy takes a while to take effect. So, the UT Southwestern data, they were saying a median time to best response was over 400 days. So, I mean, it can take a while for radiation to really show its full response rate. So, sometimes patience is key with using radiation in these locally advanced diseases, but obviously in these patients, you need to watch them very closely because we all know tumor thrombi can progress quickly and lead to really bad outcomes. So if you can get them to surgery, that's the best thing to do. But if you can't, make sure first you have a really experienced multidisciplinary team so you can talk about systemic therapy and radiation therapy. And then if you need to, radiation potentially could be used to help palliate or maybe improve their performance status, things like that.
So let's maybe now talk about the third scenario, which is the presence of metastatic disease. And truthfully, you sort of led off the last section and said, that locally advanced with the renal vein thrombus or cable thrombus, indeed, that's a pretty niche and nuanced population. I wouldn't necessarily say metastatic kidney cancer is that niche or nuanced. I mean, there's a lot of patients, either a de novo presentation or in the spectrum of their disease, that will develop evidence of metastasis. So I do feel like, and I'm interested in your thought, that this is actually perhaps one of the most common scenarios that we may all encounter in practice. Your sort of thoughts on that?
Yeah, definitely. I think metastatic disease, I think there's a big role for radiation therapy in this situation. I think there's been some good trials that have come out of, there was kind of two back-to-back trials that came out of MD Anderson that was published in Lancet Oncology, and then the UT Southwestern group also published in European Urology. They both came out in 2021, kind of close to each other. And I think, they kind of showed what a lot of us were thinking was the case, but they kind of showed it with, phase 2 data, that in these patients who have these oligometastatic disease or slowly progressing disease, there are these areas where we can use local therapy, be it surgery, ablation, or radiation therapy, that I think the main goal in these situations is trying to slow the rate at which we're giving them more therapy. So like, for example, the MD Anderson data, they looked at oligometastatic disease, and their primary goal was to see if they could keep patients off of systemic therapy by treating them with radiation therapy. They accrued 30 patients, and I think they showed a pretty good 1-year progression-free survival, which was around 65%. And so, and what they really could show is that a lot of these patients, they could delay the initiation of systemic therapy by giving them radiation therapy. And then kind of in parallel, the UT Southwestern group looked kind of in a similar situation, but not exactly the same. They looked at patients who maybe had multiple sites of disease and were on, some line of therapy, either first line, second line, et cetera. I think they included all the way up to fourth line therapy. But they took those patients and they treated some of their disease that was progressing, and they looked to see if they could delay the rate at which they would get to the next line of therapy. So the MD Anderson group kind of looked to see if they could stop any systemic therapy. And then the UT Southwestern group looked to see if they could delay the rate at which they progressed to their next line of therapy. So kind of parallel studies. And I think both studies showed that the delivery of radiation therapy could try and slow down the rate at which patients were getting their next line of therapy or their first line of therapy. And so I think what's unique about these situations is it's really, again, and what we've kind of been harping on with each, stage of disease is really comes down to the ideal patient selection. So you could see in both of these trials, the patients they selected for radiation, they had slow rates of disease progression. They had, in the case of MD Anderson, it was oligometastatic, so they had to have less than 5 sites of disease. And so, they're selecting a disease biology that isn't, rapidly advancing.
Mm-hmm.
And so that's, I think, really where local therapies are important. And I think radiation really has a role in this situation for those areas where we can't get to surgically or with ablation therapy. We've all, as urologists, taken out the, oligometastatic disease, maybe a distal pancreas metastasis or the adrenal metastasis or lymph node. Those are things we can get to surgically, which is great, but there are some areas of the body that are very difficult for us to access surgically. And I think those are great situations for radiation therapy.
Just maybe if you can comment a little bit from either of the studies that you mentioned, was the effectiveness site agnostic, or were there certain sites of disease, for example, lung versus bone, which responded better, or was it just too small a number and the analysis was really just done in aggregate?
Yeah, I don't think there was any, one site that jumped out. For example, I think the MD Anderson trial was 30 patients. The UT Southwestern trial, I think, was 20 patients. So I don't think we have enough data yet to say that one site responds really well. But, they did treat multiple different sites, a lot of times in the lung and throughout the body. So yeah, it doesn't seem at this point that I feel like certain areas are more radio responsive or radio resistant. But
And as you said, the endpoint is an attractive one in that, therapies for advanced kidney cancer and metastatic kidney cancer continue to improve. As you well know, we're often looking at doublet therapy. And although the therapies are more effective, they inherently may all have some associated systemic side effects. And so one sort of, postulates that if you can somehow delay that interval, 12 months, 6 months, a year, 18 months, I would hazard a guess that it may be quite beneficial for quality of life for the patient, but also probably gives you more of an opportunity as you keep that bank of systemic therapies full, and gives you more in the vault. Does that seem like an accurate statement?
yeah, I think in general, a lot of the studies have shown both in the primary and the metastatic setting that the toxicity, they look at, high grade toxicity, grade 3 through 5. Toxicity from radiation therapy for having high grade complications is quite rare. There's the occasion, I think I read one where there was a bowel perforation because they radiated right next to like the colon, but I think that's a rare situation. And I think that's where it gets down to the experience of the radiation oncologist and making sure that, they have a lot of experience treating these types of tumors in these kind of difficult locations that are surrounded by a lot of hollow organs, hollow viscera. But I think in general, the toxicity from, current immunotherapy is real and it can be devastating toxicities. So like you said, trying to delay the systemic therapy toxicity, if we can keep patients off of systemic therapy in those situations where they have slow disease progression and oligometastatic disease, like you said, that can be very beneficial to the patients. And I think, with modern immunotherapies, it's really interesting too, there's this whole concept with radiation therapy of kind of immune priming.
Mm-hmm.
And so, some of the upcoming trials that we're seeing in the metastatic space, there's the CytoShrink trial and there's the Samurai trial. They're kind of combining radiation with immunotherapy and then comparing it to just immunotherapy alone. So it'll be interesting to see how these trials pan out. If, is it true, this concept that radiation can prime your immune system and maybe even potentially make immunotherapy work better? So that's, kind of an unanswered question at this point.
So Dan, maybe in the last few minutes, and you sort of alluded to this a little earlier in our program, but maybe just summarize, maybe as you've read the literature, some of the limitations of radiation therapy and selecting patients. And we sort of talked about it in the beginning, but I think it would be helpful just to almost close out with some of the things that you look for and things that we should be cognizant of.
Yeah, I think We talked a lot about this. First and foremost, when I look at these radiation studies, I want to make sure, especially with like the retrospective studies, want to make sure that a biopsy has been performed so that these are diagnosed, renal cell carcinoma. And because that's really important when you're looking at things like progression and metastasis-free survival or cancer-specific survival. So that's really important, I think, with any radiation trial. I think we probably need to do a little bit better job of defining what an inoperable patient is. A lot of these trials are based on, especially in the primary setting, these patients were deemed inoperable. Well, that can vary depending on who you talk to and where they're being treated. So having sort of a consensus on what makes someone inoperable, I think, is really important because, if we're not giving them, the standard surgical therapy, that could be an issue. I think as we go forward, the radiation therapy trials will expand and we'll have longer follow-up. But I think right now we have to be careful because a lot of these trials have very short follow-up. And when we're talking about treating small renal masses and looking at their 12-month, progression-free survival, well, most small renal masses, we don't expect to progress to metastatic disease in that amount of time. So that'll be interesting to see as the data matures. And then I think one of the major issues that will, as radiation becomes more common, that we'll kind of struggle with is determining, which of these tumors are truly treated and which of these tumors are slowly progressing. And I think you look at some of the early biopsy data from radiation, from tumors that were treated with radiation. If you biopsy those tumors early, the majority of them will still have viable tumor. And you can look at things like Ki-67 index to determine viability. And I think what's been shown in some of the data is that, it takes a while for radiation to have full effect. And if you're looking at biopsies within 12 months of getting radiation, a lot of times you're still going to see viable tumor. And so I think we have to understand how radiation affects these tumors long term so that we can understand in the clinic, if I'm looking at an enhancing mass that was treated with radiation, how worried do I have to be that this is going to subsequently grow and progress? So these are kind of all questions that we still have to deal with.
No, that was really great, Dan. It was a very nice summary. And I think things that we should all be thinking about as we look at this as I think what is an exciting opportunity to sort of enhance multidisciplinary care for the kidney cancer patient. And, I think all of these therapies, one can't be dogmatic in any sense, can't always be surgery, can't always be surveillance, can't always be thermal ablation, can't always be radiation. But I think you highlighted a really great point, which is if you actually discuss these in a multidisciplinary setting, you probably at the end of the day may find the best treatment that's appropriate for, that patient with that specific tumor.
Yeah. I mean, my mentors, always taught me like, look at the disease biology, don't just treat it based on your favorite technology. And so I think that, that multidisciplinary approach is what makes us oncologists and provides us the best therapy for our patients. So I totally agree with what you said.
Well, Dan, really appreciate your time this late afternoon, early evening. I think you did a fabulous job sort of covering really all the literature or not all the literature, but the pertinent literature that I think we should know about as urologists and urologic practitioners. And very much do thank you in advance or in summary for both your time and your expertise.
Yeah, no, my pleasure. It was great to be here. Happy to talk.
For our audience, thank you again for joining us this afternoon. And for more information, please visit us at auanet.org/university. And you can certainly look at the core curriculum chapter on kidney cancer, which delves into obviously the entire spectrum of disease, but also some of the nuances in what Dr. Shapiro covered today. Dan, I look forward to seeing you soon. I hope you have a really pleasant remainder of the summer as we approach Labor Day.
Sounds good. Take care.